Thank you all for coming and spending your evening with us for an hour. My name is Chris Bell. If you don't know me, I'm the Executive Director of the Monroe County Medical Society. We're really excited to have two wonderful presenters tonight in the presentation of You Can't Give a Shot Through Telemedicine, How to Increase HPV Vaccination Rates. I'll start with Dr. Nancy Bennett, who is the Director of the Center for Community Health and Prevention and co-director of the UR Clinical and Translational Science Institute. Dr. Bennett is the former chair of ACIT, the Advisory Committee on Immunization Practices, and leads the Human Papillomavirus Impact Monitoring Project, an ongoing CDC surveillance project out of the Emerging Infections Program at CCHP. After Dr. Bennett speaks, Dr. Cynthia Rand will present. She is a pediatrician at Golisano Children's Hospital and a member of the American Cancer Society's HPV Roundtable and the New York State HPV Coalition. Dr. Rand is a health services researcher who focuses on improving preventive services and delivery of immunization for urban adolescents. She is the co-director of the General Academic Pediatrics Fellowship at the University of Rochester. Welcome to you both. Thank you for being here to share your experience and your expertise, area data, and to offer strategies for increasing HPV vaccination rates, especially in the time of our pandemic, and for doing it twice today.
Thank you.
Thank you. So I'm going to get started. First of all, I'd just really like to thank Chris for inviting us to give this talk and for you all for attending. It's really a pleasure to do collaborations with the Monroe County Medical Society for many, many years. Throughout my years in Rochester, we've worked with the Medical Society on a number of initiatives, especially those related to immunization. So it's really an honor and a privilege to continue to work with Chris on helping our community to get vaccinated. If I could have the next slide. So the talk tonight is a collaboration between the Center for Community Health and Prevention and the Monroe County Medical Society, designed to increase awareness of HPV vaccine. It has been made possible by a fund grant from the New York State Department of Health. Of course, all the views that are expressed are mine and Dr. Rand's, not anyone else's. Next slide, please. I'd like to talk a little bit about the background of HPV disease and vaccine development. And then I'll talk a little bit about a study that we're doing in Rochester as part of a national consortium called the Hpv Impact Study. And then briefly at the end, cover vaccine recommendations. And then Dr. Rand will tell us how to really get it done, because no vaccine is worth anything if it doesn't get into someone's arm. And that's really the most important part of vaccination is really being sure that we actually use the vaccines. I have no relevant financial interests or conflict of interest. If I could have the next slide. So first, just a reminder of the disease burden caused by HPV in the United States. This slide shows the average number of cancers that could be associated with HPV. And what that means is that they occur in a part of the body where we know HPV causes cancer. For each one, there's a different percentage that's thought to be actually caused by HPV, and these percentages are here. This is interesting just because some cancers are almost always caused by HPV, and other cancers are less frequently caused by HPV, but still it's the predominant cause, and you can see those percentages. And then lastly are the resulting estimated number that occur each year in the US. And you can see that almost 35,000 cancers occur as a result of HPV in our country every year. That's a tremendous burden of disease. Some of these cancers occur more frequently in men than women, and some more frequently in women than men, and some only in men or women. In particular, I just want to call your attention to oropharyngeal cancer, which causes 13,000 cases in the US. Men are more frequently infected and develop oropharyngeal cancer, but women also develop it. And so another really important cancer to keep in mind, we're going to talk about cervical cancer tonight, but oropharyngeal cancer is becoming more and more important, and especially important to remember when we're vaccinating boys. If I could have the next slide. So in addition to causing cancer and death, HPV causes a lot of other disease. High-grade cervical dysplasia, which has to be treated to prevent it from progressing to cancer, and low-grade cervical dysplasia, which also comes to medical attention. And although it often doesn't require treatment, it does result in medical care. And there are 1.4 million new cases of low-grade cervical dysplasia. So again, a huge burden of disease. And if you could go to the next slide. Also a reminder that that 1.4 million is the result of 14 million infections each year. It's a huge number of infections. There are many different types of human papillomavirus, and as you know, the vaccines that we currently use only cover 9 types, and most of the other types are less of a problem. There are low-risk types, which tend to cause things like genital warts and respiratory papillomatosis, but there are also the high-risk types that are carcinogens and cause the cancers that we talked about before. With respect to cervical cancer, HPV is detected in more than 90% of cervical cancers, and types 16 and 18 make up about 70% of those cancers. So you can see when a vaccine was developed that 16 and 18 were the initial targets for the vaccine. Next slide, please. The natural history of HPV infection in cervical cancer is a complicated one. So people become initially infected, and I'll show you in the next slide what period of time that happens. And then they often clear the HPV infection. In fact, in most cases, they clear the HPV infection. Some people develop continuing infection and may develop CIN1, a low-grade precancerous lesion that also may clear on its own. Other people with longer-term continuing infection go on to develop CIN2-3 or adenocarcinoma in situ. And then lastly, people may go on to develop invasive cervical cancer. But as you can see from this slide, that can take up to 20 years. So a long, complicated history, and hard to know exactly where to intervene in that history. And if I could have the next slide. This just gives you an idea. The peak HPV infection occurs in the teen years and early 20 years. That's when people are most likely to become infected. That rate of infection falls off considerably as time goes on, but there is a prevalence of high-risk HPV that continues. So in those cases where it is not cleared and it remains as an infection, an ongoing infection, that can go on through middle age. The cervical cancer deaths peak in middle age because, again, it takes about 20 years before these lesions progress to cervical cancer. Of course, there's a huge amount of variability in this time frame, but this is the most common. Can I have the next slide? So a vaccine was developed in the early 2000s, and this vaccine was tested, and these were the 3 dominant vaccine trials that were conducted. And you can see that the targets of these vaccines were slightly different, but the vaccines were incredibly effective. We rarely see efficacy rates that are this high. 100%, 95%. These are very, very high efficacy rates. So everyone has had great hopes for this vaccine and its ability to prevent this disease. If I can have the next slide. So the vaccine was developed starting really in 2001 with phase 1 trials for safety. It was licensed in 2006, the quadrivalent vaccine. The bivalent vaccine, which covered just 16 and 18, was licensed around the same time, and both were recommended in 2006 for girls aged 11 to 12. Boys were added a few years later, And over time, also the use of the vaccine really evolved to be use of the quadrivalent vaccine for the most part in this country. And then in 2015, the 9-valent vaccine was introduced. This 9-valent vaccine covered an additional 5 types, which were again responsible for most of the cervical cancers. So by adding those 5, we covered an additional percentage of cervical cancer. In 2016, in part due to the study I'm going to describe today, we recognized that people who got fewer than 3 doses were often protected. We know that the immunologic response is better in young people, and therefore in 2016, the ACIP recommended that adolescents who received the vaccine before their 15th birthday could receive just 2 doses. And this obviously has big implications for the ease of giving this vaccine and making sure that people get full doses. The 3 doses was always difficult. However, for those over the age of 15, it's still recommended that they receive a full 3 doses. In 2019, the 9-valent vaccine had been licensed for people over the age of 27, and at that time the ACIP considered recommendations for people who are age 27 to 45 and chose not to make a general recommendation for everyone to receive the vaccine, but rather made it a more specific recommendation based on shared clinical decision making, and we'll talk a little bit about that later on. Next slide, please. So now I'd like to tell you a little bit about the Hpv Impact Study. This is a study that is funded by the Centers for Disease Control and Prevention. It's done through our Emerging Infections program, which is part of the Center for Community Health and Prevention. Next slide. It's clearly the end of the day and I'm losing my blah. So I apologize. Just a little bit of background for the study. As we described earlier, this is a chronic disease, takes decades to develop cervical cancer. And so as a result, we realized we needed to look at cervical cancer precursors because they were a more proximal outcome, but also because they occur more commonly. So much easier to do a study at a population level with something that happens more frequently. The biggest concern that, and the reason this study was developed, was that when you develop a vaccine and you do randomized controlled trials, you're inevitably doing them on relatively small groups of people. And you're not necessarily going to detect the impact on the burden of disease in real life. So these post-licensure studies are very helpful for showing the real impact on the burden of disease in normal circumstances. That is, people getting the vaccine in their doctor's office, not in a clinical trial, people having their normal life events interfere with their vaccine schedule, et cetera, et cetera. So it's very important to know how well a vaccine really works in the community. In addition, this enables us to look at rare side effects. And I know you all are aware that there have been vaccines introduced in the past where very rare side effects were not noted during the clinical trials just because the numbers were too small. So this is also a really important reason for doing post-licensure effectiveness studies. Next slide, please. So the goals were to look at cervical cancer precursors and monitor the impact of vaccine used at the community level on these cervical cancer precursors. We also are monitoring the HPV types, and we also hope to improve public health practice by knowing what the vaccine levels are, what the screening levels are, and how those impact the disease. Next slide, please. So the methods involve diagnosing all cases of cervical cancer precursors and collecting specimens from the pathology labs to type those particular cancers. So normally when you have cervical cancer or have a precancerous lesion, it is not necessarily typed. In fact, it generally isn't. So we know what the level of severity of your precancerous cervical lesion is, but we don't know the type that causes it. So these lesions now are all typed in our community at the CDC, particularly among young women. We don't type all of them in the older women who have not had the opportunity to have the vaccine yet. There are 5 sites for this study: Connecticut, California, Tennessee, Oregon, and Monroe County. And in each of these sites, the population under surveillance is about the same size. And we do this surveillance through direct reporting from the pathology labs. We work very closely with the pathology labs. As you heard earlier when I said one of our collaborators was on the call. And we also collect a lot of information about the patients, vaccine history, screening, demographics, etc. Next slide, please. So these are data from overall, and these are women aged 18 to 39 years old. And you can see that different sites have had different declines in the numbers of cases. Our site is in yellow, and you can see that we started out with approximately 600 cases among women aged 18 to 39, and we're now down to below 300. We're actually in the 200s. So there's been a big reduction, and I'll show you a little more specific data about where the reductions have occurred. The blue line is one of our sister sites that's very similar to us, and you can see they show the same reduction. The other 3 lines are a little bit more iffy, and I think that that's due to the age distribution of the populations under surveillance. So there may be more older women who've had less of an impact. And also, some of the surveillance sites had difficulty with their surveillance getting up and running in the early days. So not uniform, but now on the next slide, I'll show you the overall data. So this is taking our data and applying it to the US population and showing the reduction in cases due to HPV vaccine. And you can see enormous reductions in young women up to the age of 25. Very large reductions. Over the age of 25, not so much, and that's because they have not yet been vaccinated. And in fact, we've seen some increases across the country in older women, and we don't know for sure whether these are significant increases or whether they're really just a screening effect, because as you know, screening recommendations also change during this time. Next slide, please. So these are our cases in Monroe County, and you can see that we see the same reductions in younger women, 18 to 20, 21 to 24, but we have also seen significant reductions in women 25 to 29. I think that's because women are starting to age into the cohort. I also think it's because we may have started out vaccinating early. Our community does a very good job of vaccination. And so I think we see some earlier impact on that age group than in some other places around the country. Next slide, please. This is just the same data as rates, but I wanted to show this because on the previous slide, it looks like 40-year-olds have huge numbers. Actually, it's just a big population, the over 40. It's anyone over the age of 40, so it's much bigger than the numbers in the other age groups. But when we do the rates, you can see that the rates are relatively low in the over 40 age group. Next slide. This is just a slide to demonstrate that we've seen these reductions in the country across all racial and ethnic groups. And this is very reassuring because there was much concern that some groups would be vaccinated more than other groups. And it's interesting when you look at the vaccination data that it's actually some of the groups that you would expect to potentially have lower vaccination rates actually have higher vaccination rates. And I think that's been because there have been really great initiatives in many of the community health centers to ensure that everyone is receiving this vaccine. Next slide, please. I did want to comment on the serotypes briefly because this is another one of our really critical outcomes. You would anticipate that the serotypes that are in the quadrivalent vaccine would start to disappear, and indeed they are in those younger age groups, somewhat in the older age groups as well, which is probably a herd effect. So big reductions in the serotypes that are in the vaccine. Next slide. Why is this happening? Well, in our community, and this is vaccine coverage in Monroe County, we've seen really good uptake of this vaccine. We have among the highest rates in the state and also in the country. However, saying that, we also have to acknowledge that 25% of our 18-year-olds are completely unprotected, and 35% are not fully protected. So we still have a long way to go. Even though we're doing better than lots of other people, we're still not doing as well as we should be. And that's why it's really important to have Cindy talk about good ways to get children vaccinated. Next slide, please. So in summary, we've documented large population impact from the HPV vaccine. It's critical to monitor populations post-implementation of vaccines so that we can see the impact on the burden of disease in the population and really know whether or not the vaccine is helping us with disease. It's also nice to see the confirmation of the randomized controlled trial efficacy, which we see when we look at vaccinated women versus unvaccinated women. And finally, the only way that we'll really use this vaccine effectively is to ensure full vaccination to reduce disease and save lives. Next slide, please. So I wanted to say a few words about the recommendations. They've become much simpler. I showed you the slide before of the ACIP recommendations over the years. There were actually years where the HPV vaccine recommendations were a little complicated. It's different for girls and boys. There were issues about age, etc. So they've become much simpler. Routine vaccination at age 11 to 12 for both boys and girls. Vaccination can be started at age 9, and Dr. Rand's going to talk a little bit about some of the benefits of starting earlier. If a child is vaccinated before their 15th birthday, they only need 2 doses. But if it's after their 15th birthday, they will need the full 3 doses. Catch up through age 26 years is recommended routinely for anyone who has not been fully vaccinated previously. And for adults age 27 through 45, shared clinical decision-making is recommended. And if I could have the next slide. Some of the considerations with respect to shared clinical decision-making have to do with the fact that people, when they reach the age of 27, are likely to have been sexually active and likely to have been exposed to HPV already. However, having a new sex partner at any age obviously confers some risk. However, it's the question of how much risk if they've already been infected with HPV. There's no clinical antibody test available, which makes clinical decision-making difficult. It would be nice if you could test for antibodies to particular strains of HPV and be able to decide whether it was valuable or not to give the vaccine, but that's not available. And so it is a difficult clinical decision. And the next slide, please. A couple more considerations are just that the vaccine effectiveness in people who are older may be quite low, either because they've been previously infected or because they may actually have developed some immunocompromising conditions that will make their response to the vaccine suboptimal. So that's another consideration in the value of giving vaccine to older people. And again, finally, HPV vaccines are only preventative. They do not have any impact once someone has been infected. So it's really a question of trying to balance, has this person been likely to have been previously infected, or are they likely not to have been previously infected? And if they've been tested and are HPV negative and are starting to have a new sexual partner, there should be some consideration of using the vaccine to prevent them from new infection. But it's really a choice that needs to be made between the clinician and the patient with full information about the likelihood of their previous infection and their likelihood of being exposed going forward. Thank you. Any questions?
If you have a question, you can put it in the chat on the Zoom there.
Or even just, since there's so few of us, even just ask it.
And there will be time for questions after Cindy's presentation as well. Okay.
Dr. Rand.
Great, thanks so much everyone for joining tonight. So I'll be talking about HPV vaccine safety, which is an issue that often comes up in outpatient settings, as well as learning some strategies that you can use in your primary care office to improve vaccination rates. And those are going to include improving your communication as well as some specific office strategies that you can use. So first, just thinking about the US vaccine safety system, there are a lot of checks to the system, which I think should instill a lot of confidence. So first, there's the VAERS, or Vaccine Adverse Event Reporting System, that the CDC and FDA collaborate on. And this is a frontline spontaneous reporting system that can detect potential vaccine safety issues. So some of you may have reported something to VAERS, a physician can report, or an individual family can report as well, which means that you have to take it in stride. So anybody can report to the system, and then each instance is investigated in terms of validity, but they don't always get all the information. Next is the Vaccine Safety Data Link, or VSD, and this includes the CDC with 8 integrated healthcare systems. It includes several of the Kaiser systems in the West, as well as the Harvard Pilgrim system, and it's a large link database that's used for active surveillance as well as research. And you can see it has a large number of members that represent almost 4% of the US population. So it's another way to very actively look at conditions. So if there was a concern that came up, you could easily look at the data on a vaccine exposure and a condition. The Clinical Immunization Safety Assessment Project is also a collaboration between CDC and academic centers that conduct individual clinical vaccine safety assessments and clinical research. And then the post-licensure rapid immunization safety monitoring program between the FDA and other partners is a large database system used for active surveillance and research, and includes 53% of the US population. So there's very active monitoring, which I think should instill confidence. And you can always go into these systems and look at reports, but usually I would just, if I was interested in a particular outcome, I would look at the summary data and then look at the CDC site, and I'll show you that site as well, where you can look at specific concerns. If a family brings up something that you hadn't heard before and you want to offer some reassurance, you can answer their specific question. So now we have more than 12 years of HPV vaccine safety data, and we know that the vaccines are very safe. You could have a reaction after a vaccination, just like any other vaccine. You might have injection site reactions like pain and redness or swelling in the arm where the shot was given, much less commonly fever or headache. And HPV vaccine shouldn't be given to anyone who has had a previous allergic reaction to the vaccine or who has an allergy to yeast. And in the time that this has been available in my practice since 2006, I've never seen an allergic reaction or an allergy to yeast, but it could happen. I have seen syncope, as I'm sure many of you have. So brief fainting spells or pre-syncope or syncope can happen after any injection. It's not specific to HPV vaccine. It's just specific to the patients who tend to be hyperventilating and nervous, or maybe just they know that they faint at a blood draw. And those are the patients that you want to have seated or lying down during vaccination and remain in that position for 15 minutes. So that is not a contraindication. So if they did that for their first dose, you would certainly have them lying down for their follow-up dose. So it's reassuring that we know the vaccine is safe, and the safety studies have been very reassuring with a very good safety profile similar to other adolescent vaccines. And you can reassure patients that the CDC and the FDA continue to monitor and evaluate the safety of HPV vaccines, along with all vaccines. And you should feel comfortable reassuring parents who may have concerns that the HPV vaccination is safe. This is the site I was mentioning at CDC that describes more detail about the safety and effectiveness data. It has specific data from all of the clinical trials, as well as specific concerns that you may have heard in your practice. I know things that have come up in my practice are the concern about premature ovarian failure, concern about POTS or orthostatic problem, a regional pain syndrome, and none of those have been found to be associated with the vaccine. But this site does address each of those concerns. So if you wanted to be able to explain that better or look at the data more specifically, this is where I would go to take a look. And the other great thing is that we know the duration of immunity is long lasting. So we have no evidence of waning immunity, and we know that there's at least protection for 12 years. And that's really reassuring, because if we're talking about giving the vaccine at 11 or maybe at 9, and we know that it's lasting for over a decade and probably longer, then we know that as teens get into young adulthood, when they're more likely to be exposed and more at risk, then they're going to be protected. So there are multiple cohort studies in progress to monitor the duration of this immunity. And we know that vaccine coverage is higher among those who report getting a recommendation from their physician. So if you look at the NIS teen, which is the National Interview Survey teen that the CDC runs, that asks questions about vaccines, you can see that 78% of teens' parents received a recommendation from their provider, and of those, 75% were vaccinated. So that's really reassuring that vaccination rates are high when you get a recommendation. Of those who didn't get a recommendation, you can see that fewer than half were vaccinated. So it's really important to give a strong recommendation, and we'll go into what that involves. So parents of unvaccinated adolescents, when they report why their teen wasn't vaccinated, you can see that the orange bar, safety side effect concerns, is the most common, and that's why I wanted to address that first. But the other issues are that it might not have been recommended by their physician, or the family didn't think it was needed or necessary. So that's where we come in really recommending the vaccine strongly, but also helping them understand why, if necessary, if they have questions, why we want them to have it. So to make an effective recommendation, it's really important to do it the same way that you do other vaccines, such as Tdap and meningococcal vaccine. Also the same day that you recommend the other vaccines. So it would be great to bundle them, and we'll go into what that sounds like. You could say, now that Sophia is 11, she's due today for 3 important vaccines. The first is to help prevent an infection that can cause meningitis, which is very rare, but potentially deadly. The second is to prevent a very common infection, HPV, that can cause several kinds of cancer. And the third is the tetanus booster, which also protects against pertussis, so she doesn't get whooping cough. We'll give those shots at the end of the visit. Do you have any questions for me? And I think what's important here is first what I would call a presumptive recommendation, meaning I'm stating what's due. I'm not asking if the patient would like to get those vaccines or if the parent would like the patient to get those vaccines. I'm putting HPV in the middle. So it's a standard thing that my practice does, and we offer to everyone. And I mentioned cancer. I don't focus on sexual activity because cancer's something that resonates better with families. And some parents might need reassurance. Most parents would simply accept that bundled recommendation because you stated it strongly, you recommended it standardly, but some might have some questions. And usually that just means that they need additional reassurance from you, the clinician that they trust with their child's healthcare. It doesn't mean that they're questioning and are really unsure about vaccinating. They're not necessarily anti-vaccination. They just might have some simple questions, and you need to address that simple question. So you want to ask about the main concern and be sure you're addressing their real concern. You don't want to start talking about the vaccine ad nauseum and give a lot of information, and you might be giving information that isn't exactly what the parent had a question about. So you really want to first find out what they're concerned about. This is a great tip sheet. It's talking to parents about HPV vaccine, available from the CDC. And at the same site, you can also find a sheet about talking to parents about young childhood vaccines. So they've developed a very similar sheet. And you can see that these are the very common questions that we get with a very simple and straightforward answer. And so we'll talk about a few of those things. The first that you might hear is, why would you give the HPV vaccine at 11 to 12 rather than later? And first, as we mentioned, you only need 2 doses instead of 3 if you start before your 15th birthday. A very long-lasting protection. And the optimal vaccine efficacy is if the vaccine's completed before the onset of sexual activity. So first, we know that you have higher antibody titers if you give the vaccine at a younger age, and that's the reason for the 2-dose instead of 3-dose recommendation. And next, just like any other preventive recommendation, like wearing a seatbelt or a bike helmet, we want to recommend it long before the patient actually ever needs it. So I would say to a patient long before they're ever even thinking about sexual activity. And this goes along with this question. I'm just worried that my child will perceive this as a green light to have sex. And you can say, studies tell us that getting HPV vaccine doesn't make kids more likely to start having sex. I made sure my child or my grandchild got HPV vaccine, and I recommend we give your child her or his first shot today. So there have been several studies looking into sexual activity related to HPV vaccine. So they looked at in Kaiser, patients who are vaccinated, and later looked at pregnancy testing, STI testing, and found that there was no increase in those things for patients who are vaccinated or not vaccinated. And you could ask, a parent might ask, how long can we wait and still just give 2 doses? And we know that the 2-dose schedule is recommended if a series is started before the 15th birthday. However, I don't recommend waiting to give this cancer-preventing vaccine. Older teens have busier schedules, and it becomes more difficult to schedule an appointment. It's best to start the series today so your child is protected as soon as possible. So you don't want to wait until a patient is 14 to try to get the 2 doses in. Really, you want to vaccinate them early. We see 14-year-olds less often than we see 11-year-olds, and so getting it in early, make sure they're protected before they could ever be exposed. I have heard this, we only want the vaccines needed for school. And you could say school entry requirements don't always reflect the current recommendations to keep your child healthy. HPV vaccine, along with other adolescent vaccines, will provide your child with the best protection. So I would first start by not separating out the ones that are recommended or required for school, but parents sometimes bring this up. So I would say, these are the vaccines I recommend, but sometimes a parent is very savvy and will look to only get the vaccines that are required for school. And so emphasizing again how important it is for the child's health, and that you and the parent want to keep the child healthy is what's really important. So then we'll talk about what you can do in your office to help increase your vaccination rates. And you have 2 options of how to improve. So first, you can increase the number of patients who come into your office. And second, you can have the number who leave the office vaccinated. So that seems really simple. So first, thinking about who comes in, this means maybe reminding patients who are due. And so this is where you do need some data to rely on. So hopefully, I didn't add anything about running a report, but it would still be very, very beneficial to first look at patients that haven't been vaccinated and look at what your rates are. And so you might want to send reminders to patients who haven't been in. We know there's good evidence for phone, text, and patient portal reminders, all of which can be effective. You might want to pick a certain age if you're sending reminders. You might want to start, say, with 11-year-olds and make sure they're coming in for their well child visits, and then send it again at 12 and make sure they're coming in again at 12. And you might also want to focus on follow-up doses. So when a patient leaves after that first dose, ideally you can schedule their 6-month or 12-month follow-up right when they leave. If your schedule doesn't go out that far, you could maybe keep a list of patients who are due in that next 6 months or at 12 months, depending on what your practice is using for an interval. To increase the number who leave vaccinated, I think the first most important thing is that strong recommendation that we just talked about. So the communication matters quite a bit. but also thinking about different kinds of visits where you can offer the vaccine. So we traditionally offer vaccines at well care visits, but there's no reason we have to do it that way. Chronic care visits are usually pre-scheduled and usually have sufficient time for a vaccine. So if you're seeing a patient for ADHD, asthma, obesity, a mental health concern, that's a great opportunity to also vaccinate them. I think practices have a lot more challenges at acute care visits because they tend to be very brief, but it's certainly also optional to vaccinate at acute care visits and really at any type of visit. When you're seeing a patient, just because we don't see teens that often. So when you see them, vaccinate them. And then thinking about nurse-only visits, this is where a standing order can be really effective. So a standing order empowers a non-physician personnel to vaccinate patients after assessing for specific contraindications without direct physician involvement. So you probably use this at a flu vaccine clinic in your practice in the fall. To do this, you need usually to have a pre-approved order to vaccinate on file, and the templates for these are all available for you at immunize.org. However, you really need staff buy-in to feel comfortable giving all the vaccines that are due. So if you have a nurse visit for a Tdap for 6th grade entry, ideally your nurse is comfortable offering all the vaccines that patient could be due for and giving them their HPV vaccine as well. So empowering your nursing staff makes a big difference in improving these rates. Another thing that can be really helpful, because all of us are very busy and easily distracted, is turning on an EHR prompt if you haven't already. So a reminder in your EHR to vaccinate, hopefully that looks at the vaccine record that's already populated. You might also include a paper prompt. And we found in a study that we did that an EHR prompt just wasn't sufficient, that you also needed to do something else. And typically a paper prompt was still helpful. Engaging your nurses and your MAs again and making this an entire office intervention really helps so that everybody in the practice is on board. And as part of our PCMH, or patient-centered medical home, we had started doing pre-visit planning and huddling. And we do this in our practice usually in the morning and then at midday. And some practices use this as an opportunity to document which vaccines are due for patients. So due for HPV. They might be on a bulletin board somewhere, electronic medical record. People have.
Cindy, you're breaking up a little bit, but. Can you hear us, Cindy?
Can you still hear me?
Oh.
I can hear you.
Okay. We can hear you now. It was just kind of getting a little broken up. So hopefully it's okay now. Sorry, Nana, you're on mute.
I was just
You
going
can
to
go
say,
to the next slide.
Okay.
Oh, go ahead.
I was going to say, if you have trouble again, you might want to turn off your camera. Sometimes that helps.
Yeah. Okay, good point. So the last thing I added is thinking about expanding the age range. You might want to consider starting the series at age 9 or 10, and actually the AAP includes age 9, and this might help because the HEDIS metric is to vaccinate by age 13. And so by vaccinating younger, you have several advantages. I think first, parents are not thinking about sexual activity at all. And so it really takes that issue off the table. Another advantage is maybe if you're giving the Tdap at 10, and we do that in our practice often because some patients are still 10 when they're starting 6th grade. So if you give 1 dose at 10, you could give the 2nd dose at 11 with Menactra. And then that's just 2 visits with 2 doses. And you could also think about using reminder recall for those patients at 9 or 10. And one of the practices that joined this morning mentioned that they're giving HPV at 9 and 10, and then giving Tdap and Menactra at 11. And I think it is really ideal to be breaking it up a little bit over time. You're also making sure you're seeing these patients each year in those really important kind of pubertal, prepubertal ages, and then they're vaccinated long before they're 13. This is what we use in our practice as a paper reminder or huddle tool. And you can see we put on there a couple different conditions. And then at the bottom, the day before the visit, the nurse actually goes through the chart and circles which vaccines the patient is due for all ages. And then that goes in a guide that goes into the patient's door so that we have that as a prompt to remind us what the patient is due for. We're maybe triply forgetful because we have our EHR turned on, we have that half sheet, and then we use this VIS sheet as well. So we made it purple in our practice, and it's there for the patient to read, but it's also there on the table as a reminder for the provider to see, oh yeah, I have to give them this HPV vaccine, so that it's really coming at you from lots of different directions. And we're able to do that in our practice because the nurses are really on board. And this is just a thought about being creative now with COVID. You're probably spending less time with patients. Hopefully you've started to bring back your adolescents. And if you have, this is an example from the New York Times of one practice in Connecticut that's vaccinating teenagers in the car. Hopefully that child is 13 and above because he's sitting in the front seat. And I think that can be a way to have potentially less face time with patients. Certainly, you would need to include a physical exam if they're there for their well child, but maybe this is his second dose and he's just getting his booster dose, and then he can be on his way. And then I wanted to give you some more information about that. The first reference here is for COVID responses, for resources that are available for improving well child and other visits in response to COVID. The CDC reference is their general HPV reference, and they have a lot of great resources, including posters you might want for your office. The AAP has a terrific HPV champion toolkit that has a great approach to kind of how to do reminder recall, how to implement a prompt. It talks a little bit about PDSA cycles and how to improve your rates. The Immunization Action Coalition I mentioned because they have that resource for standing orders. They also have terrific little short videos about patients who've had vaccine preventable diseases. So we often find that, especially for staff in your practice, you might want to show a little video about patients who've had diseases that were preventable from vaccines. I find the CHOP Vaccine Education Center terrific for their patient handouts. They're a little bit of a higher reading level, so I think if you have some savvy parents, they have some terrific handouts. Their webpage is also fabulous. And then the American Cancer Society also has really terrific resources, including, again, little videos about cervical cancer and oropharyngeal cancer survivors, and they're just 1 or 2 minutes, so a nice short little clip that I think can be really impactful to show in your office. Thank you. We're happy to take questions.
Yes, thank you both. Again, if you would like to either put them in the chat or you can feel free to ask out loud. And there's Chris's daughter.
Hi, this is Joanne Cordaro. Oh, hi. Thank you. So I don't know that I have so much as a question as a comment, but I find that I get a lot of questions about the potential side effects of the vaccine, and that's one of the things that definitely holds people back in my experience. And so I thought that that website for vaccine safety data, I think Cindy that you showed, looked like because that the one about ovarian failure.
Yeah.
Ovarian failure. So I thought that's a great site. I will sometimes try Googling, but then you get all sorts of crazy stuff when you Google. Yeah. So like good, like evidence-based data, I thought that was really helpful. And I think I'll share that with the rest of the people in our practice too, because I thought that was great. So
great.
Thanks.
That's good to hear. Yeah, the ovarian failure issue came up, I think, in response to a video that surfaces on Facebook and other social media every 6 months to a year, I sometimes was hearing it and people were thinking it was a new issue, and it wasn't ever an issue. And so that addresses it really, really nicely. I think they've come a long way on that site of responding to specific parent concerns like that.
That's helpful. Thanks.
Thank you. Does anyone else have any questions or comments? I'm not seeing any here, but we do have the PowerPoint will be available that Chris will share probably maybe tomorrow, as well as a evaluation survey that we ask for you to fill out. It should just take a few minutes. And I know that this is for also CME credit. So if you could fill out that survey, that would be great. And you should be getting that shortly. Thank you all again for joining us this evening. And to Dr. Bennett and Dr. Rand again for their time and expertise and doing this twice today.
Thanks, everyone. That email will go out about 6:40. It's already written and scheduled.
Perfect. Thank you.
Have a great evening.
Thanks, everybody.
Thank you. Good night.
Good night.
Good night. Bye-bye.
Good night.
Good night.